Culture influences leadership from two perspectives. One is in the way which we meet patient needs, and the other is the way in which we work together in a diverse workforce. Diversity in healthcare organizations includes ethnicity, race, culture, gender, sexual orientation, lifestyle, primary language, age, physical capabilities, and career stages of employees. Working with and caring for people who have different customs, traditions, communication styles, and beliefs can be rewarding as well as challenging. We will start part one of three parts of the cultural competency lessons. These objectives of this lesson are going to be to develop an awareness of one's own cultural heritage and how this affects one's approach to vulnerable populations, describe the possible conflict points between the cultural heritage of the nurse and the patient, and discuss ways to minimize cultural misunderstandings between the nurse and the patient. Definition of cultural competency and understanding of the influential factors include the demographics and ethnic composition of the U.S. population that has experienced a marked change in the past 100 years. The United States always has been a multicultural society. Variations in biologic, social, and environmental and communications phenomena can contribute to healthcare problems, and education, practice, and research issues that influence culturally competent care. First, we're going to take a look at population trends. Immigration laws have increased the number of immigrants. By mid-21st century, minority populations will outnumber the Caucasian population. The number of adults older than 65 years is increasing. The number of adults who live past 85 years of age has increased. And so what are the effects of people living longer? Well, this provides an increased opportunity for them to develop chronic illnesses. There's social isolation and depression resulting from loss of family and friends. And then primary care providers are faced with promoting maximum functional status and identifying risks to health and independence. So let's consider these factors when thinking about cultural diversity in healthcare. It is federally defined minority groups are the African Americans, the Hispanics, the American Indian or Alaskan Native, and then the Asian Pacific Islanders. Health disparities include life expectancy for Caucasians is 78 years and older, and then for African Americans, 72.7 years. The causes of death for minority groups include cancer, cardiovascular disease and stroke, chemical dependency, diabetes, homicides and accidents, or infant mortality. In African Americans, the death rate is 2 times higher than in Caucasians. Marginalized populations include gays, lesbians, older adults, and then recent immigrants from countries such as Russia, Rwanda, and Afghanistan. Their lives and healthcare needs are often kept secret, and they are often voiceless. Changing economics and downsizing. There's joblessness, homelessness, and poverty. Limited access to healthcare insurance and healthcare. High cost of insurance and lower wages make it difficult for minority groups to rise out of poverty and access healthcare. Poverty is higher cost and lower wages for minority groups. There are more minorities that lack healthcare live in higher percentage poverty. There's residential segregation, substandard housing, unemployment, poor physical and mental health, and poor self-image. Violence. Businesses, churches, and schools have become sites for random acts of violence. Unemployment is associated with violence. Homicide is the second leading cause of death among Americans about 15 to 24 years of age. It's the leading cause of death in African American males 15 to 34 years of age. Then we have the intimate partner violence. That is the greatest cause of injury in women 15 to 24 years of age across all ethnic, racial, socioeconomic, and educational groups. The range of attitudes towards culturally diverse groups can be viewed as a long continuum of intensity. According to the American Academy of Nursing, attitudes towards culturally diverse groups range from hate, contempt, tolerance, respect, and celebration. A continuum of intensity of the range of attitudes towards culturally diverse groups, hate times contempt times tolerance times respect times celebration. If you understand and integrate these perspectives, which is part of a professional role behavior, you can become competent in practice in the community of cultural diversity. So let's look at the need for diversity in healthcare workforce. Consumers' demands are becoming aware of culturally sensitive and competent care and less willing to accept incompetent care. There is a lack of diversity and ethnic representation of healthcare professionals and limited knowledge about the values, beliefs, experiences, and healthcare needs of certain populations. According to the textbook here recently, minorities are inhibited from having nursing careers, which if more minorities were in nursing, they could provide changes in the reflection of healthcare diversity. We need better recruitment efforts by other disciplines. So let's look at the current status of diversity in healthcare workforce. Although most nurses are Caucasian women, an increasing proportion of minority students are graduating from nursing programs. The highest representation are blacks or African Americans. The lowest representation are American Indians. And don't forget, we have men in nursing represent a minority. It is clear that we have been slow in preparing nurses to be reflective of our population. Before World War II, National Association of Colored Graduate Nurses existed. During World War II, the Cadet Nurse Corps had 2 black recruiters who recruited from 82 black colleges. After World War II, there were national efforts by the NACGN. There were Southern nursing schools segregated by law, Northern nursing schools segregated by Custom Brown versus Board of Education occurred in 1954. Recruitment in the 1960s and 70s. There were many efforts to recruit economically disadvantaged students. Celantic Fund provided the Rockefeller Foundation, and then we had a breakthrough to nursing. Recruitment in the 1990s. The American Nurses Foundation report of strategies for recruitment, retention, and graduation of minority nurses in colleges of nursing came out. And then we had the Chi Eta Phi, that is the National African American Nursing Society with chapters throughout the country. Then we had the nursing shortage reports, such as the American Hospital Association, Robert Wood Johnson Foundation, Joint Commission, and Association of Academic Health Centers. And then recruitment programs were indicated to have retention as their primary focus because there's no point in recruiting minorities into nursing programs and then not help them succeed. Health professionals, educators, and healthcare systems must all respond to the consequences of increasing cultural diversity for the future well-being of all populations. Reasons for cultural competence include to remember that nurses' culture often differs from the client's, culturally incompetent care is more costly, culturally incompetent care is ineffective, we need to meet the specific objectives for persons in different cultures as outlined by Healthy People 2000. Review the disparities in health and healthcare. Nursing is committed to social justice. And then we need to take into consideration such as global infectious diseases and epidemics. Since the 1960s, there has to be a united effort to include concepts sensitive to cultural diversity in nursing education. Such concepts can include beliefs and practices of various cultural groups, disease prevalence and mortality rates, cultural factors related to situations such as birth and death, specific culture-bound syndromes, roles and responsibilities of family members. And remember the essentials of baccalaureate education for professional nursing practice cultural competencies. They apply knowledge of social and cultural factors that affect nursing and healthcare across multiple contexts. They use relevant data sources and best evidence in providing culturally competent care. They promote achievement of safe and quality outcomes of care for diverse populations. They advocate for social justice, and they participate in continuous cultural competence development. This concludes part 1 of Cultural Competency lesson. If you have any questions related to course content, contact the instructor.